Hi, my name is Peter. I'm an emergency physician from Denmark, working in Stockholm, and today I want to talk with you about a topic, or actually several topics. This is a lecture I've been wanting to do for a while, and it's like a summarizing lecture of almost everything I think is important for an emergency physician to know about, and then you can go into rabbit holes on each of the topics. But I wanted to do a summarizing lecture of like what of like a summarizing lecture of most of what I've actually gone through on my channel and in my lectures, so that you can come back to this lecture and maybe delve into different rabbit holes. But this is like an overview of the entire or most of what is important in emergency medicine. There's lots of topics that might be adjacent or like tangential important as well. But I think these are some of the central topics in emergency medicine. And that's why I wanted to do this lecture. I call it strategy, or not strategy, actually logistics in emergency medicine. And the reason why it's not strategy, but more like logistics in emergency medicine, is because of this quote that usually is from the military, but in emergency medicine, it's Scott Weingart who's made this popular. Amateurs talk strategy, experts talk logistics. And what is the meaning of this? Because it's quite central. So if you have a critically ill thing, or a critically ill patient with a critical thing that needs to be attended to right away, an amateur doing a strategy would say, like, they would answer the question, or like they would do the thing as if it's a board exam. They would answer the question like what to do. Well, I want to do a lateral canthotomy because that's the answer on the board, or on the test, right? But they haven't thought through how to get the stuff to actually do it. They don't know who to call. Usually in such a halo moment, you would call an expert, or even though you would be the one performing it. You might not know whether you should do it in the hospital or someone else. Like if you are in a hospital where you have eye service, and maybe they will be able to come in time. So they haven't thought about that. They might not know the indications. Are we borderline indication for doing it, or should we not do it? Should we do it? They might not know the procedure details. They might not know like what to do if it fails, and so on and so forth. Right? They haven't thought ahead beforehand. Right? That's the essential part. Whereas an expert who talks logistics, it doesn't think about they also think I want to do a lateral canthotomy, but they have practiced they know what kind of procedures as in their entirety of their like in the entirety of medicine they know, or in emergency medicine they know which kind of procedures they might be called up for doing. They know their hospitals, so they know which ones at their local level is the one that they should perform or someone else should perform. They have they have trained both mentally and maybe even through simulation these scenarios, so they know at least basic level how to do these things if they are the ones who have to do it, and they know when they have to do it when the indication is there. They also know the caveats and how it if it fails, how to do things. Even if the nurses don't know where the materials are, then they know where the materials are, or at least if that bucket or that cart with the materials in it, if that's not there, they know where those materials are. So they have an entire different kind of approach to all of this emergency medicine, right? They have thought ahead. They know what kind of scenarios can occur, and they've trained for it. They planned for it. And so Weingart would say they know also how to perform the nurse's job if the nurse doesn't know where it is, and like they are responsible, and they do the things to achieve what the patient needs, right? So that's the difference between amateurs and experts, according to this, to the Scott Weingard's quote. And I think is a good example of this kind of mind shift that we need to have in emergency medicine, and that I wanted to convey in this lecture. How do we actually plan so that we can do things smarter, so we know ahead of time, or at least as much as we can ahead of time, what to do. How can we plan our residencies so that we train these things at a regular basis, so that we do get into all of these things. And I won't go too much into training, but I will go into some of the I'll refer you to to that rabbit hole in links, but I'll kind of just summarize some of the things that are important for us, both as specialists but also in residency, to know like what kind of landscape is there to become this expert. How do we achieve this? Exactly. So we want to take the strategy, what to do, and think ahead of time to achieve it. That's what logistics is. Okay. The disposition of this lecture is I'll do a quick introduction, because we know, and in the introduction will be mainly about what our priorities are in emergency medicine, and that's a discussion. That's a topic for that you can delve into as well. Then in part one, I want to talk about the stable patient and probabilistic thinking mainly. In part two, it's a critically ill patient, and also probabilistic thinking, but more so what you call like iterative process, ABCs and sign-ins and such, and how to run a code on a critically ill patient with your team. Then, as part of this, I will do a separate lecture on non-technical skills, which is something I've talked a lot about and I love talking about, but it's something that I haven't done a full lecture on, like a summarizing lecture. So I've tried to achieve this with this part 3. And then part 4, I'll talk about something that becomes more and more relevant as you become more senior in the emergency department, crowding and flow, and logistics of like the entire emergency department. Okay, so let's go into it. References. Usually in my lectures, I will do references. For this, it would be such a huge list of references. So I would my go-to reference here is I've done lectures on most of these topics. This is a summarizing lecture, right? So I've done lectures on most of these topics, and I will refer you to those lectures, because in the beginning of each of those lectures, I will have references. And if they're not there, then I have blocks on my on acutmedicina.dk, where plenty of references under each heading you can find them there. Or you can always, if there's a specific thing, you can always write in the comment section or write to me if you want a specific reference. Okay. From time to time, when I think like to help you go down a rabbit hole, if you want to, if there's an area where I want more knowledge about this, more than I can either give you or have time to explain here in this lecture, then I'll show you this, like something like this. For instance, the quote about amateurs talk strategy, experts talk logistics, is very well summarized in this short but amazing lecture by Scott Weingard, where he summarizes all of his mind of the resuscitationist kind of things, which is a long-running blog on his MCrit page where he summarizes this. So it's really great. So I'll put in these references as we go along. So you know, like if you want to delve into this, then you can go there. I'm not an expert speaker, especially not in English. So I would encourage you to double the speed of the video so that you can get through it quicker. And all of my ums and maybe and pauses, they're like evened out or removed. Okay. Okay, introductions. What is our priorities in emergency medicine? What do we do? Why do we have to exist in the system? I usually show you this, and it's my kind of way to say what our priorities is, what our priorities are. It's the time critical conditions of the individual. It's compassionate care, or numbers need to treat equals 1, meaning that each patient, we need to make each patient better as a result of the meeting that we have, doctor-patient, and not worse at least. Doesn't mean that we have to treat them, treat their condition or cure them, but we can always make them a little better. We could give them advice, and we could give them a pillow if that's enough. We can give we need to make the encounter. We need to strive for making the patient a little better, or maybe sometimes a lot better, but at least not worse. Through our encounter, through communication, through all of these things. And then zero-sum game. We in emergency medicine, but also in other specialties, but more so in emergency medicine than in many other specialties, we have flow and access block and crowding. It's not just the patient in front of us, it's also the patients in the waiting room. If I take too much time with one patient, it will be time that I haven't used on another 10 patients in the waiting room, and they might be sicker. So there's always this tension between those two, and that's also part of the emergency medicine. So this is what I think are our priorities, and which one is the biggest one? It's usually the time critical one, but they interact and it depends on different patients. That's usually how I explain it. But I'll just show you how others explain these things and see how it relates to what I'm saying. So if you want to delve into where did emergency medicine begin and why was there even a need for it, then I can recommend checking out this evolution of emergency medicine video that was, I think, made by ASEP, or the junior organization of ASEP, a few years ago. One of my colleagues in Acute Medicine.dk has made a timeline of this from in Danish from the first emergency medicine or first emergency departments until and throughout where we are today, and this is mainly the Danish development. I'm sure there's a Swedish one somewhere as well. If you want articles on this specific topic, then there are some articles, but these are some of the legendary ones, like the Peter Rosen, the one the Peter Rosen who made the book, Rosen's, which is one of our Bibles, along with Tintinelli's. Made this article, I think in the 60s or 70s, called The Biology of Emergency Medicine, where he talks about what is emergency medicine. And then Brian J. Sink has made an update or comment on this a couple of years later. Both worth reading if you want to delve into the history and what our priorities are. And there's also many books, amongst which this is one of it's like a book where they ask a lot of emergency physicians about what are our priorities in emergency medicine, and it's a good read, and I think it's free on iTunes still, or it can be bought for quite low amount of money, because emergency medicine is also changing, and Scott Weingart and Simon Carley has made this emergency medicine is the failed paradigm lecture, which is really nice to listen to get into yes, emergency medicine might be a good idea, but what are the problems about it, and why is it maybe a failed experiment and in some places, and why we need to constantly think in medicine in general, because there's such an abundance of overuse and things that just don't want to die in emergency in medicine in general. So if there's an area of medicine that is not needed, then we should die. So we constantly have to think, is this really the best way to go? a few years back, Paul Atkinson and Grant Innes and Ken McGeorge make this like saving emergency medicine is less more, and they also made a podcast about it in EM cases and MCRIT. And so in general, the critique is like it used to be like everyone emergency medicine used to be like 24/7, 365 days a year. Everyone can come all the time, and now maybe because the threshold to come in is different in many places. It's not the patient's fault, but maybe culture-wise, we are more afraid of dying, or we're less used to the idea. Even Illich would say that the institutions like medicine have made common folks or people just inept of taking care of themselves in a lot of ways. So they don't know when you should seek for diseases and so on. This is one of Weingart's arguments, like the threshold for when to seek. Like in emergency systems where there's an open emergency department where you can just walk in from the street, then there's like where patients self-select themselves, then this becomes a problem, and like the floodgates just opens into the emergency department. It's really, once you're there, it's hard to get you good care in accordance with the Lyon principle, where you like, because if there's too many coming in, then you just have to take blood samples on to make flow go through, like, to make the flow go better. So there's huge problems in this, and I've talked about this in different videos as well. We will talk about it in part 4 as well, about crowding. But what Paul Atkinson and Grant Innes argue here is, well, maybe we should change the narrative a little bit. Maybe we shouldn't be everyone all the time. For like, maybe some of the patients that could be followed up in different ways should be followed up in different ways, and so on. So this is the topic of crowding, and it's like a huge thing that you can deep dive into and still not quite get it, but we'll talk about it in the end of this lecture. Just to say that what emergency medicine is different in different countries, and what we do will therefore be a little bit different. It's not like neurologists who usually do kind of the same thing in different countries, or other specialists. Emergency medicine is very much our place in the system is very much based on what kind of system we're in. Some places we need to be the intubators and do things in the emergency department because there's no critical care. Other places where there might be other needs that has to be done by the emergency department. But so there's this tension between, should we be able to do everything? Probably not. We shouldn't. We need a core, and this is the core that I want to go through with you here today. What are some of the core things that I think, despite which kind of system you're working in, these are like core things that we need to know. Just another example of like what are the priorities of an emergency physician. This is from DASEM, Danish Association of Danish Society of Emergency Medicine. And what is the emergency physician's competencies? And they write, or we write, because I'm part of this as well. leadership of interdisciplinary teams. Both with critical patients and so on. Capacity and flow. Like we have to manage the flow in the emergency department so that there won't be crowding. Emergency procedures. Educating and supervising personnel in emergency medicine competencies. Plan and lead. And also, like, if something big happens, catastrophes and so on, be able to handle that and plan for that. Have knowledge about probabilistic thinking and also a differential diagnosis, and then coordination of where to go, like disposition, you usually call this in English, like where to go, primary care, secondary care, and so on, Do you have to go in to the hospital? How does the patient go on from the emergency department? And then patient safety in the acute. So I agree with a lot of this. A lot of this is under my time critical thing. It's just a little bit bigger. What I'm lacking is something like compassionate care but otherwise it's very much in line with what I would say as well. And that's the thing. It's hard to like encompass all of this. This is what the USM says. I'm not sure when it was written, but I took this in December 2025 from their homepage. Emergency medicine is primarily a specialty established using the knowledge and skills required in the prevention, diagnosis, and management of urgent and emergency aspects of illness and injury affecting patients of all age groups with a full spectrum of undifferentiated physical and behavioral disorders. And prevention, they say, also includes injury prevention, preparedness for disaster, as well as public health education. Management encompasses the local service organizations as well as the development of systems to provide EM care. Time and timing in the setting may be critical either from a medical or from a patient point of view. And in hospital as well as out of hospital triage, resuscitation, initial assessment, telemedicine, and management of undifferentiated urgent and emergency patients until discharge or transfer to the care of another health care professional. So that's what USM thinks. I know that there's been like USM has to encompass the entirety of Europe, right? And in some countries, prevention is not such a big thing, right? And I know there's been a lot of discussion whether prevention is core for us. Maybe it is in areas where you don't have alcohol, like where you don't have a good system to pick up alcoholics or drug users. We might be the only place they go, and therefore prevention might be really important here. But in other systems, you do have a somewhat well-developed system where you can but you can refer them to other places. You might have to pick them up, but you don't have to make the entire prevention thing. But I know like in North America, especially I know in Canada from their podcasts, this is a big thing there. But it might not be as big a thing in Scandinavia. It depends. It's because prevention is usually something that is done in primary care. I would say prevention I will do advices from for patients once they've been injured, how not to injure themselves again, but not in details. Preparedness for disaster, I agree. That is something that we do. And public health education, that is probably a little bit too wide. We do inform patients, like we will come to the communication with patients about what can you do in the emergency department and what should you do in other areas of the healthcare. But I do that. But I mean, in a perfect system, I wouldn't have to do that. And then that's I guess the tension. Do we live in a perfect system where we don't have to do prevention? Is this part of my numbers need to treat equals one? It probably is sometimes. So I'm not quite settled whether prevention is like, it's not a main thing for us, but it might be in there sometimes for us to do. Yeah. Okay. And then the pre-hospital thing in Europe, yes, but in Scandinavia, controversial. So depends. You can check out my lecture on the pre-hospital setting here in Sweden if you want to go into that rabbit hole. Okay, one of the people who said it best, I think, is Ruben Strayer. He made these like the responsibilities of the emergency physician. And up highest is resuscitation and identification of dangerous conditions and symptom relief. Determination of disposition level is also in the dangerous one. Management of flow, yes. And then he has this called customer service. And we'll go back to that. Resource stewardship and public health. So he would also agree that public health is part of it. And I can't remember. I don't think this is a prioritized list. I'll give you the reference soon. But I want to go back to this customer service thing, because I actually agree that we'll talk about where customer service fits in. I don't think customer service is our prior one. Like, the prior one for me is the critically ill patient, right? But a big part of it, like most of the patients we see in the emergency department, especially in open systems when you can just go in from the street, like we have in Sweden, but not in Denmark or Norway. At least not most places in Denmark or Norway. You will have to have some kind of customer service as part of your numbers needed to treat equals 1. So it's good to have, but it's not essential. Kind of. If you're in the middle of the night, there's not like customer service goes down the priority list as opposed to when it's more calm, right? But you cannot in the middle of the night down prioritize treating critically ill patients, right? So here are the references. If you want to, like, he's talked about, like, this lecture is legendary for emergency thinking, and he's done like podcasts on this recently as well, and also this EM cases where he goes through this. Like, this is really recommended reading if you want to like go into what is our goal, priorities, or priorities in emergency medicine. Okay, I just wanted to side by side show you that I agree with most of this. So my one up here, symptom relief, that's the same as my number one, like or my like numbers needed to treat equals 1. Resuscitation and identification of dangerous conditions, yeah, that's my number 3 here. Again, this is not a prioritized list. I would say this is probably prior 1, but these are what the arrows are for. It's like it's interrelated. And sometimes the time critical condition is not as important because the patient is palliative. Then it's number 2 to treat, like, so you get it. All right. Then determination of disposition, that's about flow and access block and so on, and management of flow, yes. And then you have public health. I haven't got public health here. It might be part of numbers needed to treat, and it's also like discussed in the USEM, so it is somewhere in there. Resource stewardship. I haven't. I'm talking about that in my overdiagnosis lectures, mainly from a standpoint of what harms the patient, and in that way, it is part of like numbers needed to treat equals 1 and also time critical conditions. But resource stewardship and it's also part of the flow. If I order too many CT scans, and the flow will like be bad. So. But not as much as like antibiotic stewardship and stuff like that. I haven't specifically put that into my, like, of course that's more like the responsibility of a doctor as a whole, not so much for the emergency physician, I guess. And then customer service. I always say, like, this is like the patient usually comes into the emergency department and asks, what's wrong with me? And I usually try to first validate what they're feeling. That's horrible that they're feeling like this, and they feel like they're in such a bad way that they have to go into the emergency department in the middle of the night for this. My purpose, I'll like try to manage expectations right away. My purpose is to rule out something dangerous. I can't, like, knowing what it is often something that is done outside of the emergency department. If it's not something dangerous, then it's better to use the time as a test. Most things will go over by time. Especially if you come into on day 1 or day 2, then it's better to let time go and not get a diagnosis right away, because it's better that way most of the times. So there's a difference between like what it is that is hurting or that is the problem, and that is not something that is the main goal to find out in the emergency department. But as part of the customer service, we can compassionately talk about this. We can do what I just did, talk about manage expectations, and then say, like, it's actually because it's like dangerous to go further on. Oftentimes, like I like knowing what it is specifically is can oftentimes like lead to a lot of like iatrogenic damage if it's not dangerous, right? So let time go a little. I will, and then we can make a plan for them, right? That's a customer service. And trying to find out why are they there to begin with. were they afraid? Were they like, why did they specifically come in today with this problem, right? So customer service, I believe, is really important. But and we can talk about whether our patients are customers or whatever, whether it's more holistic. But I think the notion that the soft things, like all emergency medicine, is not just about time critical conditions. I think that's really important, and it is encompassed in compassionate care or numbers needed to treat equals 1, I think. Okay, so that's it for the introduction. Kind of like, what is emergency medicine? What are priorities? I think this is usually what I bring up to like kind of just encompass what we are. I might update it at some point. There might, as you see, there are some nuances that are not mainly like totally clear in my definition, but it's simple. One thing I forgot to say is, like, I usually say, like, time critical conditions are system dependent. So what do I mean by that? Well, a time critical condition in a system where you can be seen by your primary care physician the next day or have a decent follow-up, well, then many of the conditions that are somewhat time critical, they can just be followed up tomorrow and see, like, you can be tested for with blood samples, and then they might not be that time critical anyway. Your potassium was 4 today, and it was or 4 yesterday, and now it's 5 or 6. Maybe it goes up, maybe it's not. In a system where you cannot be followed up, then tomorrow with blood samples, then then you have to be admitted, right? So there are some elastics to what is a time critical condition, depending on the systems and how much you can follow up a patient, like the day after or the 2 days after. So in the system I work in currently, I can't follow up anyone. Like most patient groups cannot be followed up. Like, it will take weeks usually. At least not reliably. They might be able to, but I cannot reliably say that it can be followed up. So I need another plan for most of these patients, which often means admission. Which I wouldn't have done when I worked in Denmark, where you could send them to their primary care physician the day after. So time critical conditions, yes, there is a core of time critical conditions. We know what we think about, but if we think about it a little bit broader, then there are certain conditions that are not, in some systems, time critical, and in other systems they are. Cancer is another one, and there's a discussion as well whether they should be worked up in, at least not in the emergency department, but some cancers might be delayed too much by sending them, or some workups might be delayed too much by just sending them home, because it will take weeks or months. And sometimes you just have to do it in an emergency department. But I know that's a dicey discussion. It depends on which system you work in. In general, no, cancer is not, like, as long as it's not a cancer that is very dangerous. For instance, acute promyelocytic leukemia is a very dangerous cancer, right? You have to work that up in the emergency department to rule it out, so that they don't have a head bleed or something, or another bleed, right? So that's a cancer that you have to work that up right away. But finding a lung cancer that is not dangerous, or brain tumor that doesn't give you epilepsy or anything, like, finding those things is not something that is actually part of the emergency department. It depends on how high the risk is, right? Again, but a pancreatic cancer that is obstructing bile, so you get a cholecystitis or something like that, that is something that is a problem, right? So, or cholestasis, right? So it depends, right? These are nuanced things, and it's something for discussion. But this is my take on these things. So now we'll delve into these time critical conditions in part 1 and part 2, and then we'll go into, in part 3 and 4, we'll talk more about like the numbers needed to treat equals 1, and the more like a flow access block kind of thing. Okay. So part 1, the stable patient. So if we have a patient coming in, usually they'll be put in, like in most emergency departments I've worked in, they'll be dealt into 2 groups. The really sick, critically ill, where you go into the resus bay, and there's usually some kind of criteria either some kind of triage criteria or pre-hospital criteria. If there's trauma, might be trauma criteria, depending on, and then you'll go in here. And then on the other end of the spectrum, you have the patients that are walk-ins in some systems, or in most systems they will be walk-ins. They'll walk in from the street, having had symptoms for a short amount of time or a very, very long amount of time, and wanting to be worked up, right? And again, just when I'm talking about like these patients walking in, it's not their fault. It's the system's mainly it's the system failure that they are allowed to come in. It's not their fault. They're trying to do everything they can to usually not go into the emergency department when you ask them, right? So it's for the most part not their fault. It's a system failure, and that's how we should look at it. So we shouldn't convey hatred to our patients because of that. You can check out the waiting to be seen blocks by Howard Ovens if you want to go into that rabbit hole, and like why does the patient come in, why like if you're bothered by the green patients, like the green triage patients that sit on the mobile phones, then please read those blocks. He delves into like the arguments why we shouldn't, and I think that's correct. We shouldn't be mad at those patients at all. It's not their fault. And or you can just ask them, how was your way, how was your road to the emergency department today? And most of them are embarrassed by going to the emergency department. They don't want to be there either. They just want to be helped. The patient doesn't want an MRI or a CT scan. They want to be symptom free, and we have to be consultants of their health to try to make sense of their symptoms. And we specifically in emergency medicine need to use the lens of, is it dangerous or not? And if not, then you can go here. All right. And it's a spectrum, of course. And the triage is not perfect. Some of the patients that look like this are really sick, like the APL patient that I just talked about, acute promyelolytic leukemia. Or neuro patients, they might be under triage as well. They might look like this, but are not. So it's a spectrum, right? But in general, so in the first part, we'll try to talk about these patients that are not only walk-ins, but are not sick. That's like 90% or 90% of the patients in the emergency department. They're not critically ill. They're not like we have to run to them right now. They're not prior red. They're prior green, yellow, or maybe orange is. Yeah. Some of the models, and this is part of what I also wanted to do in this lecture. I wanted to show you some of the models. You already know some of the models if you've seen my other lectures, but I want to emphasize these models are important. These models are something that I, within this topic, use all the time, and I'll try to use these pictures, kind of like Polaroid picture frames for these. Like these models are important, and when we talk about the stable patient. Okay, so we'll go into these. I've also delved into this, like if you want to, here comes the references, right? So if you want to go into details on these topics, then go into these lectures that I've made. There's references of people who are better at explaining this than I am. Most of this is really like is theory, but most of this, like probabilistic thinking of the stable patient, is learned through case-based learning. So you need to be out there in the clinic, see patients, and then talk to someone, hopefully someone like me or someone who actually knows like these things in probabilistic thinking, and like so you can like utilize the theory, because the theory is a little bit hairy, but then you can utilize it, then it becomes alive. It's kind of like point of care ultrasound. You need to like see the first patient where it actually is really important, and you need to find that pleural effusion where it changes management to think like this. That's where you like, oh, POCUS is the great, like point of care ultrasound is the best. That's the thing with this as well. You need to like learn it, do it, and then you'll find out that, oh, this is really core. Some of the others who have made great videos on this is Justin Morgenstern / Casey Parker. Has made this YouTube video called Mastering Diagnosis, also amazing. Smacked Up. Also Broomdogs or Casey Parker has done this Diagnostic Odyssey, also great. So if you want to go delve in, check out these we'll just go through it, and I'll try to do it from another perspective than I've done before, so that you get something new here as well. So, as I said, our prior one in emergency medicine is we want to find this like marriage between the time critical things and the likely things. This is where we want to kind of, if the patient presents with a symptom, we want to take which time critical things could it be and what is most likely with the data that we are presented with, right? This is where we want to see whether we should rule out or rule in this thing. That's not how they think in most other places, right? They in most other parts of medicine, they would think like, what is the cause of their symptoms? We don't think like that. We don't do this long list of things that could be wrong with the patient, because that's irrelevant for us. Because our priority is to rule out what is dangerous, what could kill them right now, what could harm them, what is mobility or life threatening or sight threatening for them right now, right? And I'm saying right now, as I said, in different systems, it might be in a couple of days, in a couple of weeks, depending on what amount of follow-up they have and what kind of, like, if you see a patient who's an asylum seeker, for instance, they cannot be followed up anywhere. They don't have any. They have basic rights, but in many systems they fall between the chairs. Work them up a little bit more, right, in the emergency department, because they will not be able to follow up. They might not be time critical right now, but they will not be able to follow up. So it's elastic, this, but in general we will always think about these things. Okay, that's our priority. It's a yeah. So, but why shouldn't we just why do we have to think like this? Why can't we work up everyone? It's a balance, right? Because we want to rule out the like time critical and likely things, but if we start working up too many things, right? If we don't if we do CT scans on everyone, just like everyone, like you see maybe 10 patients a shift or so, like and if you see all these patients and you do CT scans on all of them like on selectively, then you will create crowding. You will create a lot of problems with most of the patients, right? You will create overdiagnosis, and most things they regress to the mean. Most symptoms, I think, is Bernard Lown, who in his book Lost Art of Healing, it talks about most things that people seek with is the rough and tumble of life, right? It's biopsychosocial, and the psychosocial is like a volume button, right? So you dial up, like if you have a small symptom, somatic symptom, then it will be dialed up if you have high amount of psychosocial stress. You might be you might have and this is something that can happen to everyone, all of us. Some might be more prone than others, but we all have that volume button, right? We all have these days where something hurts more, and then we might hear from a friend that, oh, she also had that headache and that was a brain tumor, so we might get more afraid of it. And then we might develop what we call hypervigilance, right? And some doctor might give us hypervigilance, where you like, oh, you zone in on your body more. You try to like scan your body for any symptom at all, and you try to put it away, but you can't, right? And you're reminded of it each day, and it grows and grows, and at some point you can't like push it away. And then, like, if you don't seek someone at the right level, like if you go to the emergency department and it's a high flow day, and you might get a test, but that test, like when you actually should have had a conversation with a primary care physician, right? So, and we in systems where there is no, like, where we also have to kind of act like the primary care physicians, because it's people walk in from the street, then it becomes like that, right? So that's inefficient. That's not according to what you call the Leon, Leon principle. it's not the best care at the right like the right level of the right level of care and the right like place in the system. It becomes someone who seeks for a symptom that is probably could be dealt with in a primary care. Goes into the emergency department, and that's a problem. Most of the patients that I see, or a majority of them at least, will have that kind of like, it's not something dangerous, but you need to, like, we have to explain that to you. And I mean, so doing CT scans on all of them would be a problem. It will create crowding. It will create patients where we shouldn't. You can go into the O diagnosis lectures to know more about that. Yeah. So most of what I do is actually like kind of manage these expectations and communication. Okay. On the other hand, we have like customer service. All right. The patient wants to know what it is. I mean, they want that CT scan, or they don't want the CT scan. They just want it to be symptom free, right? But sometimes we might actually have to do that CT scan to actually facilitate the flow. I mean, I don't have time for that kind of, I don't have time for the conversation right now because I have 10 other patients to see. The CT scan is being done, and the conversation to not do the CT scan takes too long. But it would be better if we try to have that time. And then we do most of the time, but sometimes, it's not possible. And then these patients do get that CT scan that might not have been needed in the emergency department. And sometimes they like have gone for a long time, and they haven't gotten the help that they don't feel they've gotten the help that they needed. And then sometimes you do need to do the customer service thing, but it's really hard when like, usually the best thing is usually to compassionately talk with them, and that would be the customer service in this. And do shared decision making and what you call deliberate clinical inertia, like deliberate clinical inertia from Kaiser's, Gerben Kaiser's article with the same name a couple of years back. Like, just don't just do something, stand there. Like, it's okay to have worked you up and not do anything actively. Like, I purposefully said you should just go home and wait. And if you can convey that in a way so that the patient knows that you are not afraid of anything, and then they know what to do if something goes the wrong way, then usually they will be happy with that. Okay, so about this, amateurs talk logistics. Amateurs talk strategy, experts talk logistics. In this case, like for all the symptoms that patients can present with, I've just mentioned a few. We should be able to have a database of illness scripts for like what is time critical and what is likely, right? So I'll go through through it right away. For chest pain, for instance, but we should all have a library of illness scripts. Of like, for chest pain is the 6 big ones. I'll talk about them right away. For dyspnea, you can have the dyspnea pyramid, as also something I've gone through in other lectures. For dizziness, is like stroke is the main one, but there are several others. I've done that in the dizziness lectures. For headache as well, I've done that. And you can sometimes put them into like syndrome specific, like thunderclap headache, the headache of a pregnant patient, and so on. So and abdominal patients with shock or not with shock. So we have to have some kind of like list of all of these, and if you take a list of all of these, then Ruben Strayer, for instance, have made like a list of like the time critical and likely diagnosis of all of these symptom presentations that he thinks is important. This is not like a total list, but it's a good start, or it's a really good start. It's like most of the things that we should be expert in. And we should be expert in exactly these things, because then we are planning for the events when it happens. We know what kind of tests are good or bad, what kind of likelihood ratios are, like, which questions should we ask, how do they usually present, and how can we how can we make the best like logistic choice to make these patients go through the emergency department so that they don't become overcrowding, so that there isn't any so there isn't misuse of resources, and it's hard. It's hard when they seek on the day number one, right? And so that's part of why Scott Weingart talked about the emergency medicine as a failed paradigm, because they were allowed to do that. But yeah, but that's the essence. We have to build up our archive of illness scripts from all of these, and each illness script we need to know the epidemiology, the diagnostic tests, and the likelihood ratios of the diagnostic tests, meaning questions, vital parameters, and how they usually present, both typically and atypically, and so on. And then the treatments and the procedures of these, each of these illness scripts, right? Okay, going into this. So these are the models that are really important here as well. I usually draw this, and I might not have explained it in detail, or how I use it, but I'll explain how I use it now in daily life. So every time someone comes and consults me, or I try to do teaching in this area, I will, once you get to the discussion of what kind of diagnostic, what should we do, what do we think is wrong with the patient, in the stable patient. Well, you have the time critical things, and you have the not time critical things, and you have likely things and the unlikely things. And what we focus on these things, right? But there are some nuance to that, and we'll go into that. And then we also have the time, depending on when we're seeing the patient. If you don't know anything about the patient, you just know it's a patient with chest pain, then it's the time is zero. You don't have any vital signs, you haven't seen the patient, you don't know anything, not even the age, not Mabel's, not OPQRST, not anything. Then it's time zero, right? And so these are where these, this is where the main focus for the emergency physician should be. But you also have this one, where it's not the non-time critical, but likely. This is mostly what is wrong with the patient, right? We might not know exactly what it is, but this is what, and there are why should we care about this group? Well, there's at least two reasons why, maybe three. So the first and foremost one is that when we rule something out, I will go into this in a little while, you can either rule out these directly, or you can indirectly rule them out if you have if there's a good test, meaning that there's a high likelihood ratio on that test, meaning that when you can safely rule in something here, meaning that the likelihood of these dangerous diagnosis goes down accordingly. An example I usually use is BPPV. If you have a dizzy patient, then if you can surely, and in a Peter Johns kind of way, the nystagmus pattern and all, if you know that is a BPPV, then it's very unlikely to be a stroke, right? Unless they have two things at the same time. Hickam Stixum, we'll go into that as well. So that's the first thing. You can indirectly, you can spare them a lot of the more expensive workups if you can safely diagnose one of these things. Sometimes you can, oftentimes you can't. That's the one reason why we should care about these. The other reason why is about compassionate care, symptom relief, and so on, because everything else in this group, sometimes we can diagnose something, sometimes we can't. That is all customer service. It has some importance, but it's not the prior one. So sometimes we might not oftentimes it's dangerous to go further because they're under the threshold. It's better to just time will tell. Usually most things are rough and tumble of life. Time will tell. The time as a test is best here, right? But sometimes it's not the best way to go. And sometimes they do, sometimes you want to talk a little bit with them and give them, usually get them advice. But diagnosing someone with, sometimes if it's abdominal pain, if it's chest pain, then it might be gastritis that is here. And then you have to, I can start you in symptom relief, omeprazole. or another PPI, and then if you're older, you might want to go to a gastroscopy, and I can send you I can order that, or I can make that happen, and so on. So that's also part of the customer service. It's not essential, but it's important, so that they like. And I might order that myself if I have a good system where I don't have to follow it up, or I could send you to your primary care physician, and that's another step for you. But so I might do the customer service thing to just order it myself if it's fine and it's not dangerous, because I can't work, I don't want too much things to I don't want too much. I don't want to see the test afterwards. I don't want to follow up on the test results. Someone else has to do that. But if I work in a system where I don't have to do that, then I might do that, right? So these are the reason why these are important. But bear in mind, it's not good to get a diagnosis like don't be too sure on these, because we don't have good tests on these, like musculoskeletal pain, Tietze syndrome, all of these. My opinion is that we should probably not make diagnosis of these unless the patient has had a long time and with these symptoms, and it helps them to have a diagnosis. But that's overdiagnosis thinking, and all of these. You can go into those kind of lectures of mine and of others to go into that. So let's go through as an example with chest pain. With chest pain, I usually say there's six, the big six, and two of them is the heart. Like there's ACS and perimyocarditis, or whatever the ESC 2025 guidelines now calls it. The two lungs, pulmonary embolism and pneumothorax. And then the two strange ones, or others, which is aortic disease, acute aortic dissection mainly, and then upper GI. And upper GI can be exploded into cholecystitis, pancreatitis, sometimes, like if it's for specific conditions, a incarcerated paraesophageal hernia. You can have a Borg-Haber syndrome, like esophageal rupture. Yeah. So these are the ones that we want to rule out all the time. There's plenty of non-time critical ones, usually gastritis, or musculoskeletal pain maybe, or like biopsychosocial anxiety, all of these things, right? What is the trigger? I don't know, but the main thing is the button of psychosocial things have been screwed up a lot, like to going up to 10. So that's why you're feeling all these symptoms, right? So that's that. For a different one, thunderclap headache, you have subarachnoid hemorrhage and RCVS for the time critical ones. And then you might have a long list of less likely ones that could present with thunderclap headache, but not usually does, like sinus venous thrombosis or spontaneous idiopathic hypotension, neck artery dissection, and so on. But going back to these chest pain examples, because that's usually the easier one to go through, let's put them out like this. So you have ACS and all of these things that we just talked about. Instead of having time 0, now we gather some data. The data says that this is a chest pain patient who's 60 years old. Let's say it's a male. And then we do what you call the Maples Plus medicine, allergies, previously previously diseases like diabetes and so on, leisure or social things like what do they do for work and so on, and ethanol, and then smoking, like drugs and so on. And then I usually put a plus, because vaccination, yes or no. For pluses for specific cases relevant for your case. Here it might be hereditary conditions like cardiac disease in young age and so on. And then you do your OBQRST, your onset, your position, your quality, your relieving factors, what makes it better or worse, severity and timing, the temporal aspect. So if you had to make a graph of it, how would it look? Would it like spike and then even out, or was it like more upgoing and so on? So that's the temporal aspect. And then you have a plus there as well, meaning that some symptoms you have to ask about other symptoms relevant for the chest pain. So that might be, do you have dyspnea? Do you have upper GI bleed symptoms or lower GI bleed symptoms, so on, depending on what is relevant, right? Because we can't ask all the questions all the time, right? We need to pick out which questions are of most importance. Again, logistics instead of strategy, and the background for that is like our illness scripts. That's what we build, and we know what kind of likelihood ratios, what questions are really important for the diseases that we think are important here. Okay. When we talk with the patient, we don't use checklists right away. We ask them broad questions in a compassionate care way, and we'll go into. I'll probably refer you to another lecture on that, because I've talked at length about how to talk with the patient. So I won't go through this here, but just know that I have several lectures on that, and how to like not lead them down a rabbit hole by asking specific questions too fast. For this specific patient, he says the gradual onset over minutes over minutes, and there's radiation to both arms, no dyspnea, and that's the details that we get. So we might then say, okay, it's probably not pneumothorax, it's probably not aortic disease just from the history, and we might also say, oh, it's probably not PE because there's no dyspnea. It's not the pain is not pleuritic, and then we kind of, at this point, I think sorry, I moved too quick. At this point, then there is maybe 3 diagnoses left, like there's ACS, maybe pyramidal myocarditis, and maybe upper GI things, right? So now we have to like kind of fly ahead of the plane. What do we do? What is how do we rule this out? So already, like when we approach our patient, usually we're taught in med school, like, oh, we have to do a systems review, like you have to listen to the chest and so on. And yes, maybe there are reasons to do that. There might be a compassionate care component. The patient knows that the stethoscope is important, right? They feel that they're being examined, quote unquote, when you pull out your stethoscope and you touch them. So that's important in and of itself. Okay, but from a diagnostic standpoint, then outside of the ritual of like examination from a doctor, then we need to know as emergency physicians where's the money, what is the most important things. Like for ACS, okay, we need an ECG, we need a troponin, right? And we need probably 2 troponins depending on at which point of their condition since they're the onset of the symptoms they're seeking. Okay, so for pericarditis, you need to like know the workup, and this is also like, if you know the illness scripts, then you kind of know the workups of all of these things already. So you fly ahead of the plane. Fly ahead of the plane is a central concept that will going through all the time in this lecture, because where you're standing now, like, okay, I know like this is a workup for this patient. Then I can already now say, okay, to the patient, I can manage expectations. Okay, from what I hear, now I'll do an examination of you, but if everything looks okay there, then it's like you have to take the troponins and an ECG. You'll probably stay here for a couple of hours, and so on. Like, you have a plan, and once you go back to your seat by the computer, then you can sit down and you can write about the patient right away, so you don't have to do it later, and then you can like cognitively deload because you have a plan. If the troponins happen to be positive, then you know, like, then it's an admission. If the troponins happen to be negative, well, do I need another one? Yes. Then I'll know. Well, once the troponin comes, then when that is negative, then I'll have to order another one. But if that is negative as well, do I then send the patient home? Well, yes. That's the plan, right? So and if that's not the plan, if you think that patient's history is too dangerous to send them home, if you're afraid of unstable angina, then you have to admit them, right? Unstable angina, because then the troponins and ECG would be normal. So already that can be gathered from the history. So you need to fly ahead of the plane. If this happens, what then? And if you can do that in a good way, if you can like incorporate this into your management of each patient, then you can almost always have a plan for them right at the bedside. And once you go back to your computer, even though you might have to give this patient to another doctor because you have to go home, then you already have the plan, right? You're cognitively deloaded because you don't have to think once the test comes back. You think beforehand. And also sometimes, if the test is like usually in abdominal, especially in abdominal pain patients, you will think, okay, so this patient has flank pain, is 40 years old, and has never had kidney stones before, has a little bit of blood in their urine, but also has quite low blood pressure, and maybe some. So there might be. Do we want to see this stone or not? Like, it's probably a kidney stone, but like the lowest risk kidney stones, they can just be sent home to be worked up. So the first question is, do we want to see this stone? Well, maybe, yeah. And if so that's a CT scan just without contrast to do that, or an ultrasound in some places, but usually a CT scan low contrast. But then you can ask yourself, okay, if it's a patient who is a little bit older, then the main differential is the aortic dissection, the aortic aneurysm. And should we, if the CT scan is negative, then can I send the patient home then? No, I can't. Then I'll have to at least either rule out now by clinically rule out this like maybe aortic aneurysm, or I'll just have to order an aortic dissection or aortic aneurysm scan right away, and a arteriography. And sometimes the older the patient gets, this is more and more important to think about, right? Do I need contrast if there's no kidney stones? What if? So this is like an example of flying ahead of the plane. If the test like is negative, what do I do then I have to, like, you have to think a few steps ahead when ordering. It makes your life easier in every aspect. Sometimes the right answer is to, okay, you will do a sequential testing. That's okay. But then you can tell the patient, okay, there's a long wait. I have to admit you because I first have to do a CT scan, and if that is negative, then I have to do another CT scan with contrast, and if that is negative, then I have to, so on and so forth, right? So always ask yourself the question: do I want to send the patient home after this workup? Is that okay? And if not, then you have to admit them, right now, if there's place for the spot for them. And also, if the test is like, no matter if the test is negative, and it doesn't change management, and if the test is positive and it doesn't change management, well, then probably don't do the test. Okay, so we talked about these two strategies for ruling out these dangerous conditions, right? You can either rule out directly, which we talked about, like you can do troponins, you can do ECGs and so on. That's a direct rule out. If it was a P, you'll do D-dimer, and you might have to do a CT scan after that. But you can also do rule out by ruling in. And that's also what we talked about. If you have the non-time critical conditions like BPPV, then you sometimes can rule out the dangerous stuff by diagnosing one of those securely. Again, I'll talk about this in these lectures. So what we're talking about here, if it was DVT, and you have a patient A, who has a swollen leg, you might be suspecting a DVT. Then you have this, we call it probabilistic thinking, right? You call it a pretest probability. Let's say patient A has a high pretest probability, a high Wills score. We are time zero maybe, or time 5 minutes. We've gathered the data with them, and we are afraid of that they might have. There's a high likelihood for them to have it. Then we'll do a test, and the first. What we want to get the patient down here. We want to get them under what you call the threshold of acceptable missrate, right? It's usually 2% or something like that. I've made it bigger here so that it's easier to see, but it's usually around 2%. How to do that then? Well, we need to do a test, and that would be a D-dimer in this case. A D-dimer has a very, very good negative likelihood ratio. That means that the error here is very steep downwards, but it has a really weak positive likelihood ratio. So it's almost like a positive likelihood ratio will not do much to the pre-test probability or the post-test probability. If the likelihood of the patient having a DVT beforehand was 80%, then it's now 82 or 85% or something like that, if it's positive. But if it's negative, if this is 80, then maybe we're down to 40, 30%. That is not low enough, right? So even if you start off really high and you really need another test, right? You need an ultrasound. And if that is negative, sometimes the patient has such a high risk that you need to do a second ultrasound at some point in the future, but they are low enough risk that you don't have to treat them right now. Yeah. Let's introduce another patient. Same. This is a patient who has a lower risk. And here, the D-dimer test is negative as well, meaning that we don't. And then this patient has such a low pretest probability we didn't have to do anything more, right? We can also think of a third patient, patient C, who clinically we don't really suspect it's clearly not a DVT, but because the patient came in with swollen leg as the presentation, like in the triage system, it said swollen leg, an assistant nurse like put in that, then it was automatically picked up that they did a D-dimer that happened to be positive. What do we do then? Well, as I said, the D-dimer is what you call a one-sided test, meaning that it's good on one side, but it's not good on the other side, as opposed to a double-sided test, which is good, like has a good negative likelihood ratio and a good positive likelihood ratio. Ultrasounds are like that. CT scans are like that. Some blood samples are like that. For instance, amylase and lipase for pancreatic disease or pancreatitis are good, both negative and positive likelihood ratios. Okay. So that's just really short about probabilistic thinking when we just think about one diagnosis. Okay. So let's go back to this where we have. So we do our system review of the patient, but what we actually want, like if you only are allowed to order 3 tests, which tests would those be? Like for upper GI, I just want to press their belly, because if they're not hurting, I mean, you can have severe disease with without belly pain sometimes, or just subjective belly pain or upper GI / thoracic pain. You can have that, but usually you'll be a specific kind of patient. You'll usually be a frail patient or a neurodiverse patient, and then I have to then my test of palpating the stomach will not be good enough. But here in a patient that is like otherwise healthy and not that like should be okay. And if that is okay, so then the pericarditis. Well, how to rule that out? Well, there's 4 criteria, maybe 5 criteria now with the new 2025 guidelines from ESC. But so it's like you have ECG changes that are like specific, or common for pericarditis. So you need to have an ECG. You need to do a stethoscope or auscultation of their heart to see if there's a pericardial rub as a second criteria. Third criteria is typical pain. So you need to specifically, if they haven't said it already, you need to specifically do the test and ask them specifically, does it hurt when you're like in different positions? It's mainly, and we are looking for if they're lying down. It hurts, and it gets better when they're moving forwards, or when they're swallowing. Does it hurt when they're swallowing? That's also one of them. Or do they have pleuritic chest pain? That's also one of them. So that's the third criteria, like chest pain that is typical for pericarditis. And the fourth criteria is PECs, like point of care ultrasound. So at this point, I might plan to do an ultrasound, and especially if I think this is a low risk patient, then I might, because then usually it's easier to get them home. Like there's lots of studies saying like if you do a little bit of ultrasound, then the patient feels more examined, and if I in a shorter amount of time can make the patient feel more examined, that's good. But I also need to know the risks that doing a comfort ultrasound or customer service ultrasound, or what do we call it, does create the risk of finding incidentalomas and so on. I have an entire lecture of when the CT scan lies and what the risks are of an overdiagnosis and so on. So there are some risks there. So I might do it depending on ACS. Here I'll do troponins and an ECG as well. So now I kind of had the workup, right? So that's what we will do. This patient that doesn't have any GI symptoms when we ask, and the abdomen is non-tender. There's no like pericardial symptoms. ECG is okay, and there's no CRP. That's the fifth, the new one. And there's no ROP, and we might do a POCUS, seeing that there's no pericardial effusion. And then you do ECG and troponins, right? So then we have our plan. That would be a directly rule out. You might also have the indirect rule out, right? You might have pneumonia. Like, what could it be? Well, it could also be pneumonia. Sometimes pneumonia is very, very critical, but then usually they won't. Chest pain is not the usual thing that will present with. They will usually present with sepsis or dyspnea or something like that. So that's usually not just chest pain. That's usually not the case. So it might actually go down into unlikely. But and then usually it's gastritis. Well, gastritis, yes, it could be gastritis. That's like this entire group usually makes up at least times 0. This entire group usually makes up maybe 10-15%. The pretest probability from studies of all chest pain patients usually say that ACS is maybe 10%. Pulmonary embolism is like 2 to 5%, depending on the studies and where it is. Our GI might be a few percent as well. Aortic dissection is really low. Pneumothorax is really low. And pure myocarditis is quite low as well. So it might be maybe 10 or 15%, right? That means 85% is this, right? But we don't care about that unless there's a good test. So is there a good test for gastritis? Well, you could give them Gaviscon or Pink Lady or anything. Gaviscon is just as good as Pink Lady in the studies, or at least not worse. So you might as well give them that. But that's like a symptom relief thing. You should, but if you're doing them, if you're using that as a diagnostic test, that's not good, because placebo effect, and patients may just by time be symptom relieved. That doesn't mean that it was the Gaviscon. Like it's not highly specific, and that's the problem. It's not good enough as a test. The likelihood ratio is not good enough. So the arrow, like the likelihood arrow, doesn't go high enough, so that like when this goes up, this should go down, and the arrow here is not big enough. It's just a small arrow, meaning that this doesn't go down enough. So in this case, we might not be able to rule out by ruling in. We'll just delve into what criteria I think there should be to rule these, like use these to rule out the dangerous stuff. So we'll go through this. So in general, again, now I've just plotted this 2x2 table, and I just took the non-time critical but likely, the one that we had on our upper right, and the time critical and likely, the one that we have on the upper left. So as I just said, these are maybe 10 to 15%. This is maybe 85%, and then the unlikely ones, I haven't. They don't matter right now. So, and then we have our threshold from our other model before, right? So that's the acceptable missrate threshold. So how far should this be for, like, how far down should we be in likelihood for this to be ruled out? Because we can never go to 0. And if we try to, we'll hurt the patient, right? And we'll hurt a bunch of other patients as well, because getting to 0 with this patient means that we should do this with every patient, right? Or almost always. Like, that's the logic, right? Why should they? And doing that would be usually doing CT scans on a lot of more patients, reducing the hit rate. So we need to find some kind of Goldilocks zone here, and usually that's 2%. What's been said in pulmonary embolism literature. Okay, so we want to try to, instead of directly reducing this by directly ruling this out by tests, we could try to get this up, right? And when can we do that? When does it count? When can we do that? Well, we assume that the sum of all like differential diagnosis for the presentation is 100%, meaning that the patient has only one cause of their symptom. It's only ACS, or it's only gastritis that is the reason for their pain, right? But sometimes they do have different things. They do have several things. For instance, if you have a patient who has had or a cough for 10 days and might have had COVID, but also now presents with a worsening of that. They might have their pneumonia, right? They might have, even have COVID or another virus. If it was influenza, they might have Staph aureus, but they could also have pulmonary embolism, right? They could have both, because we know that they get more thrombogenic with these things. So the cough might represent pneumonia. It could also be, if they're short of breath, it could also. Sometimes you need to think about hiccum dictum. Like patient doesn't. It's not just one thing. It's several things. And when do we have to think about that? Well, I would, as a rule of thumb, I would say the critically ill. Like if you have shocky patients, which we'll talk about in the part 2, if you have a shocky patient, then usually there's not just one reason for their shock. It might be both dehydration, but also vasoplegia because of sepsis, right? And also the heart is failing because they're an old person now in the critical condition, right? So there might be different reasons, especially in critically ill patients. It might also be an elderly or neurodiverse patient, which makes it difficult sometimes to, like, they have a baseline of symptoms that are quite high, and they have a lot of like baseline things that could be wrong with them, and then there might be more than that. That doesn't mean that you shouldn't be able to like rule in BPPV on a dizzy elderly patient, but I'm just saying that polypharmacy and other like things can contribute to this, and making this kind of rule of like this thinking a little bit more difficult, so that you might need to use the direct way instead of the indirect way. And then if you have prolonged symptoms, as I just said, with someone who has a cough for a long time after pneumonia or COVID or so, they could also have pulmonary embolism, or they could, like, that's just an example, but like someone with cancer of the lungs could also have pulmonary embolism. They could have pleural effusion. They could have several things, right? So for most patients, the sum is usually 100%. There's only one cause of their condition, but for some, you have to think about hiccum dictum, and if there's hiccum dictum, then you have to think about several things, right? And that's also something you have to think about when we ordered a scan and we found that the patient had a kidney stone over their flank pain. Okay, but the patient is 90 years old, has a blood pressure of 60. You did a non-contrast CT. Are you sure that there's nothing else, right? It could be a aufstängt pylit, like a infection in the kidney stone, creating sepsis, but it could also be an aortic aneurysm that is missed on the non-contrast. So you always have to think about these things, even when you have what you think is the answer on the CT scan, right? Does it correlate? All right, then the second criteria is that you have to have a highly pathognomonic test, meaning that likely ratios has to be good. The arrow has to be high, right? If it's a high arrow here, then it can press down a lot. If it's a small arrow, then it's not a good test. For instance, Gaviscon for gastritis is not a good test. For instance, nitro is not a good test, because nitro, it makes everything better usually. It's placebo and so on. Or it can, like, it's not specific enough, at least, to rule out, for instance, aortic dissection or any if you have that suspicion, right? So, and then yes, you need to get the third criteria is you need to get it under the threshold, right? The arrow has to be big enough so you get under the threshold, and you have to think, what is the threshold then? Where is the threshold? Well, the threshold is just an imaginary thing. There's no definition of the threshold of acceptable missrate. I'll talk about it in a little while, how we can think about this threshold and where we should put it. But in general, it's the threshold goes up or down depending on how bad the disease is. So it's a really bad disease, then we will have a higher threshold. We'll have a lower threshold. It needs to go down to maybe, instead of 5%, you have to go down to 2%. If it's an aortic dissection, for instance, you want to be sure. Especially if it's something that can be treated, right? If it's something that can be really well treated, like aortic dissection has good treatment, but maybe if you're 90 years old and you're in an elderly home, then it is not a good option. The prognosis of the patient, right? And then also, it's also about how bad or good is the test. If you have a really if the test is not really good, and then and it can go. Sorry, I can't remember this one though. Check out Broomdog's lecture on this. He goes through these in detail. The Odyssey 2016 that I showed you before. But in general, like, the threshold can move. That's a point, and it depends on what kind of disease you're trying to rule out. If it's a bad disease, then usually you want to have a lower threshold, right? And then you have to have a better test here to rule that out, right? Okay, getting back to our patient here. And we will just remove these. We said perimyositis is not it, and it's not upper GI. Okay. So this is kind of what we have left. And ACS, let's say, I mean, can we use gastritis here? And we already talked about it. Well, the sum is usually 100%. This is probably the only reason why, right? Do we have a highly pathognomonic test? No, we don't. We just don't. Gastritis we don't have a good test for gastritis. And even if we did, we might come into like the Hickham's dictum even so, because lots of patients might have a little bit of gastritis, but is that a significant enough find? If we could go into in the emergency department to do a gastroscopy, would a little bit of esophagitis type A or a little bit of, would that really be enough? I mean, if it's a big ulcer and if they're really big, I was still okay. But why do they have ischemic symptoms out? So there. I mean, even if we could have a good test here, I'm not quite sure that I would use it as a rule out, even though, especially as old, if the patient gets older, right? And we don't get under the threshold, so we can't use the indirect way here. But if let's say instead of a 60-year-old, it was a 20-year-old with gradual onset, no radiation to both arms, and no dyspnea, no nothing, then, well, ACS, I guess sometimes when I started my career, we wouldn't take troponins on these. Now we do, but I guess it's okay to take troponins now and then on these patients, especially if they have concerning symptoms. But the thing is, could we use gastritis as a rule out? Well, maybe it's probably just that symptom. Do we have a highly pathognomonic test? No. Are they under the threshold? Yes. After the troponin workup, they will be under the threshold. And sometimes, I mean, ACS is such a low risk. Like, if they have belly pain in the epigastric region and they don't have any ECG changes, then maybe you don't need the troponin. Then you just need to send them home, right? And do try Gaviscon. So it really depends on how the age of the patient, what the pretest probabilities and the risks are, right? Because here in a young patient, the ACS is like started off right down here, and it's really borderline on the threshold usually. So should we work it up or not? Well, it depends, right? Especially after we'd heard the history that they don't have any ischemic symptoms, no like, so understand this. I should explain this well, right? So young patients can have ACS. That's why we sometimes need to take the troponins, but we shouldn't screen everyone with a chest with troponins when they're 20 years old, I think. If they have other signs like ulcer or epigastritis, they have they have other specific symptoms. Then even though these symptoms, this is not so good, then even small arrows are okay when the pretest probability of the dangerous stuff is lower. Okay. So maybe in this patient group, the Gaviscon is good enough. I don't know the studies on that. but maybe that is good enough. If you don't have any other concerns, if they don't have any concerning history, the ECG is normal, then maybe you don't need the troponins. I'm just that's like this line of thinking is what we want, right? It has to be dynamic, and depending on which patient we have in front of us. And then we might go to the studies, and I might be wrong. I might say, oh, this threshold is actually a little bit higher, and therefore this test is not good enough. Well, we don't know these studies, and most of what we do is share decision with the patients, right? And what to do and all. Okay, just to get this in on, and it's not mainly related to this, but likelihood ratios is on a spectrum, right? So you do have, or symptoms is on a spectrum. The the quantitative value of the symptom is important, right? So either with, like, you have something like diarrhea. Sometimes patients just say, oh, I have diarrhea. Okay, and that means just 1 or 2 stools more than usual, and it's just a little bit looser than usual. That I would not call, like, I'm not, it might be defined as diarrhea in some definitions, but it's not really what I'm afraid of, right? I'm afraid of watery diarrhea 10 times a day, right? That's more what I would say. And sometimes in the studies it just says, oh, diarrhea plus minus, and I mean, it's important to know that it's a spectrum, right? And also with cough and with some symptoms, like it's a spectrum with the symptoms, and so when you see a likelihood ratio of, oh, it's +2 or +5 or +10, like, okay, it's also how was the patient asked, right? Does the patient give you that symptom freely? Like, did they say that they had the thunderclap headache, or did you have to ask, did you have to pull it out of them? So I think the likelihood ratio, there's no, I believe, there's no studies that I know of on this, but how we gather the data has something to do with how good the quality of that data is as well. How much can we rely on that? And also it happens on, another thing about likelihood ratio is what kind of studies were they done in the ED? What amount of expertise do we need? For instance, on POCUS, it has amazing sensitivity and specificity, meaning that the likelihood ratios are good. But can I perform at the level of that expert that performed that? I'm not sure I can, and that's why POCUS is usually not a rule out; it's rule in. But with experience, it becomes more and more of rule out. But it's on you if you rule it out and don't do it in a good way. Then instrument reliability as well. Like, I might not be able to perform the same, so that the likelihood ratio in the studies is not exactly like the same as I would say. So there's always, like, all of our tests are a bit with confidence interval around them, right? And how big the confidence intervals are depends on our expertise in that specific test, and the quality of that specific test, right? And also the qualitative description of that test, right? So, was it diarrhea 10 times a day, watery stools, or was it just a little bit? So there's nuance here that is really important, that it just doesn't come out in the studies, right? And did the patient freely say this, like spontaneously say, like, oh, I had thunderclap headache, or I had this, or did we have to pull it out of them? That's also partly something. So there's detail to this, and there's art to this, and that's just another thing I wanted to say. We also have to think about this, right? In the emergency department, this goes into the probabilistic thinking kind of way. Like, our probability of error is biggest in the beginning, and we are usually here in the beginning. Primary care is usually even further out, so we have to cut them some slack as well, right? And then on the ward the day after, or like if we see the patient after the primary care, how could they be so blind? Why couldn't we see this? It's just important to be humble, and to not indulge in tribalism, saying that we are better than the others. Usually we aren't. We're just seeing patients in a different timeline and in a different way. And sometimes, yes, we might be more expert in certain areas. That's why they come to our emergency department from the primary care, because they want our opinion on it, right? So, but that doesn't mean that we wouldn't have made the same choice in that situation given the data that we collected, right? So it's the choice in the situation that is important, not what it turned out to be tomorrow when more data was available. And that gives rise to what you call the retrospectoscope, meaning that the people on the ward or we in the emergency department look back on like the level before us and say, how could they be so wrong? Why did they treat this patient in the ward? Why did they treat this critically ill patient with antibiotics? It was clearly not a sepsis. It was hypertension because of tamponade or whatever, or it was hypertension because of something that was found out the day after. Why did they? Because we were over the threshold, right? We were over the threshold for treating in that time critical situation. It was low risk to treat, and it was better just to give them a shot because we didn't know what it was at that point. That doesn't mean it was an estimation. It was a qualified guess of risks and risk evaluation, right? And I use the antibiotic example because that's something that often comes up. And Scott Weingart usually says that he will, in any hypertensive patient where he doesn't know what it is, he will give them antibiotics. And because a lot of patients with sepsis is common, and sepsis without fever is common as well, right? So I can understand why. So that gives rise to that retrospectoscope. It's important also to just give the probability of error. We usually talk about error of missing something, and that's usually in the critically ill patient. We don't want to miss. We want to do more so that we don't miss things. We want to give antibiotics even though we are not quite sure, but we don't know what it is, so we just give it antibiotics anyway. But we also, in the stable patients, we have to think about the overdiagnosis, right? Especially in the stable patients, we need to think about the overdiagnosis things because that's where we can harm them as well. And we don't measure that in a good way. It's hard to measure overdiagnosis, but it's really, 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 really important. So error is not only underdiagnosis, and remember that it's also overdiagnosis. There has to be a balance. And we talked about this, like a good decision. I've talked about this oftentimes, but in general, it's really good to remind you of that a good decision. So sometimes like we make a good decision and there's a good outcome, but sometimes there's a bad outcome. It doesn't mean that the decision wasn't good, right? It just means that the patient it was a pulmonary embolism. We did all the things that we had to do, but they died anyway. That doesn't mean but if I'm in this situation, I will often feel a little bit bad and second guessing myself. And that, in this case, is really good to just do what you call like shadow boxing with one of your friends or your co-workers or in your group. It's like, this patient presented like this. What would you have done? And then they will write or talk with you and say like, and give them the same data as you got, or even just what data would you collect here? You have 2 minutes to collect it. and describe the situation that you're in. You have 4 patients down in the waiting room, or 4 patients on your team already who's like critically ill. You don't have too much time for this. Try to do that with your group or with a friend who knows emergency medicine, right? Then you will find out that they would have done the same, or maybe they've done a little bit different. That's how you become better, right? There might be 1 or 2% that you could have done differently. But in the main, like most of the time, your good decision was good. It was just not meant to be. And on the other hand, you can't do bad decisions. Bad decision, good outcome. Well, you send all the patients with thunderclap headache home. Well, it's like only 10%, around 10% of the thunderclap headaches, monosymptomatic thunderclap headaches that will have a subarachnoid hemorrhage. Maybe a few percent more will have something else dangerous, but you'll be right you'll only be wrong 1 out of 10 times. That doesn't mean that the decision is good. You're still over the threshold of like what acceptable miss rate, right? You wouldn't want to miss 1 in 10. You want to miss 1 in maybe 100. So that's the thing, right? And that's sometimes difficult to tease out. Was it a bad decision or was it a good decision? And it comes down to like what do you think the risks are? And how do we know that? Well, that's through our illness scripts and what the data we gathered was. And when we look at what the data showed, what the patient had, what the patient said, and what we gathered, and when we compare that to the dangerous illness scripts that we thought, then we can kind of like gauge, okay, where are we in our like thresholds, and where are we in our what are the dangerous conditions, what are we afraid of, and then you can like kind of tease out, well, you need to do this every time next time. You shouldn't send home the thunderclap headaches, or Simon Carley's professors in emergency medicine. Simon Carley's example is, well, you shouldn't send patients like you can go a long time in your career you can go and not examine the skin of feverish babies, right? You will only pick up meningococcal septicemia or meningococcal disease with the petechiae maybe a couple of times in your career, but that doesn't mean that you shouldn't do it. So you can go around and send people like or pediatric patients home without looking at their skin in detail for a long time, or you can send old headache patients home without looking at their Horner syndrome or like pupils for Horner syndrome as well. Like so you like go doing this exercise, like not only can you make yourself feel better, but you can also like get in small details by shadow boxing. Shadow boxing with experts or other colleagues, and seeing, okay, what would you have done here, and then you can feel like, okay, I'm calibrating myself, I'm doing good enough decisions, right? The problem is with this, the real problem is if we all make bad decisions sometimes, and it's not a dichotomy. This is a spectrum as well. Like this, everything usually is a spectrum, but this is not like you do have some some decisions are momentarily like really bad, but usually in the context they were kind of good. Like it was the least bad decision that could be made. But sometimes you just make bad decisions. Sometimes you're tired. Sometimes you don't know about this condition or whatever, and the patient had a bad outcome, and then that happens as well, right? And we need to, and we'll talk about that in the non-technical skills part. We need to have a good environment to pick up people, and we shouldn't like criminalize that, because we can all like we can all, or we will all from time to time through our career have one of those decisions that turn out bad. And that's just how it is. It's a game of numbers, and we should not criminalize this, because then no one will work here, and we will not learn anything from it. So that this is Sidney Dekker and his like human factors. We'll talk about like human error and all these things later. But that's and how to go about it in a better way. Okay, in the end of this part one, I'll just talk about typical and atypical presentations and this concept of acceptable missrate. So in general, our illness scripts, let's say our illness scripts for something is this big, is ACS illness script. What is it made of? Well, it's made of book knowledge and maybe the culture where we work, like how do we usually work up these patients, and then guidelines, and maybe a little like before we even see a patient, or when you are a med student, then that's how it looks like, right? But with time, with maturity, with experience, we will see that the patient sometimes, like all chest pain patients, like all patients with ACS don't present with chest pain. Sometimes they present other ways, and sometimes you do have to take a troponin even though it's not chest pain, and so on, right? And that doesn't mean that you're overdiagnosing or working up. It's just because you know that some groups just happen to present differently, right? So with experience and pattern recognition, and especially when the pattern doesn't really fit, then that's when you like mature, and your illness script becomes bigger and more mature. So a patient that is typical, both the expert or the experienced doctor out here and the novice will pick this up. But sometimes the atypical presentation of ACS or any other condition, right? Now we're just talking about ACS. Atypical presentation here will not be picked up by the novice, but will be picked up by the sphere of the expert. And that's why we always want to, when we're a novice, we have to have this balance, or like as a doctor, we have to have this balance between being competent and knowing that we're competent, so we don't have like imposter syndrome and all, but also be humble and knowing that we could be wrong. There's this like yin and yang situation where you have to contain both of these, and know when we are an expert and when we're not an expert. Just because we're a doctor, doesn't mean we're an expert in all fields of doctoring, right? That's silly. And it's the same in emergency medicine. We might not be experts in all fields of emergency medicine. We have to have a certain rate of expertise in some area, in all areas that passes for good like doctoring. But we are less expert in some areas. That's just how it is. And therefore it's good to ask colleagues. Like the humble situation will make us ask colleagues, and do that often, and also do it in shadow boxing manner, like in a teaching environment. Like, what do you do here? And yeah. But we don't only think about one diagnosis at a time, right? We saw that earlier. We think about several. So illness scripts of ACS, PE, and or aortic dissection. We can think about those because they usually are overlapping. Yeah, these symptoms were like all of these overlap. These are called non-differentiating features, like chest pain, troponin, ECG changes, shock. All of these patients can present with that. But you can nuance it, and you can nuance it, and you should. If it's sudden and intense, then we think the green one, or dissection. If it's more pleuritic, then usually we think, but it's still not enough to like rule out the ACS still, right? So we need different things. We know that with ECG changes as well, like if it's a STEMI, then it's 1 in a 200 chance that it's an aortic dissection, as compared with ACS, where it's like 199 of those with STEMI would be that, even if they have sudden intense chest pain. Okay, and the same with shock. Well, what kind of shock? You can through POCUS see that, this might, if these are in shock, it's usually it's a tamponade. If these are in shock, it's usually LV failure, and if these are in shock, it's usually RV failure. So you can like check out those things, or it might be a arrhythmia in the ACS as well. These things are called differentiating features. It's like it's overlapping only between like a few illness scripts, not all of them. So that might be dyspnea, for instance. And this is what you call a key feature, right? So this is only pathognomonic for one. It might be, as I told you, STEMI is really pathognomonic for ACS. It's very rare to have a STEMI in aortic dissection. And this is also accordingly, the likelihood ratios will like fit accordingly, right? So and we don't have to have calculators in our pockets as emergency physicians, but we need to kind of know when are we differentiating one thing from another, and what kind of questions do we listen for, and that's how that's about the illness scripts. Like that's what we listen for. Like PE, the chest pain in PE is usually pleuritic, right? And if it's a infarct, but the main thing, like, it's not chest pain that is main reason for waking up chest, like the PE, it's usually dyspnea, right? And then I think I didn't mention when we were talking about PE is that what you call creep and our definition of a disease might also change our illness script, right? So a PE in the 60s would be a patient that would be critically ill because we only did CT scans on those. Today, the patients would probably not, like, a lot of patients have a PE. Like in the 2000s, Dr. Wells has said like when he developed the PE, like it should not be used. The Wells score should not be used on everyone with a chest, but more and more we are doing that because sometimes we do find PEs then the question becomes: is this a symptomatic PE, or is this just overdiagnosis? And is there a reason to find that small non-symptomatic PE in these in patients? So because then we can develop a treatment before then we can treat them before it cascades into a bigger thing. I mean, and if we think of PEs like that, then yes, then the amount of patients that we have to work up becomes much bigger, and especially with PE, there's this tension: should everyone with a chest and everyone with should all of those be worked up with D-dimer and troponin, or is it only pleuritic chest? Like dyspnea we get, right? If they don't have fever, don't have anything else, right? And then we think this might be PE, then we should work that up. But chest pain is difficult, right? If they don't have features of this, if they don't have features of ACS, and they don't have features of this, and they don't have perimyocarditis, and you can't find anything else, then sometimes you're prone to do the D-dimer just because it's easier. But sometimes you just might, it's a discussion, right? It's a discussion whether or not to do that. And it's about the creep, and it's about how good our CT scans have become to find these small PEs. If you want to go into details about that, check out Jerome Hoffman's lecture on YouTube on overdiagnosis. He talks specifically about how when our test becomes from microscopes to electron microscopes, right? Then we can see small things, and it's not always good to have such sensitive tests, especially early on in this diagnostic process. As Gilbert Welch, the writer of Overdiagnosed, the book also says, and I talk about that in the Overdiagnosis lecture as well. So you can check that out if you're interested. Okay, yeah, and we do OPQRST and Maples. We've gone through that. Okay, so let's pick out aortic dissection for once here. So we do have some. If you have a patient that has aortic dissection and it's like a textbook presentation. Oh, it's like it's sudden intense chest pain from a Marfan patient who has it's radius to the back, and it's migrating and it's ripping, and all of this. They say it spontaneously. That's like right on the money of your illness script, right? That's really rare, usually. And then the other one that was like, it's obviously not dissection. It's like a young 20-year-old who doesn't have a sudden onset chest pain, just some chest pain, and it's palpable, and it's when they move around it hurts, and they don't have Marfan, and they did a CT scan yesterday that was normal. Like, it's obviously not this. That's also like that's not too rare, and that's something we use all the time. But then you have like what you might call a slam dunk diagnosis, right? Where your chest pain patients is very overlapping. Like they do have sudden chest pain. There might be some features there's not entirely like they also had like some pain out in their arm maybe when you ask them. But most of it fits the picture, and then you definitely like you're over the threshold to just do the CT scan, right? That's also like there's a slam dunk diagnosis. But most of the patients that we see, they are in the borderline, right? They're in the borderline. Should we or should we not? They're like I have in my head while I'm doing these bubbles. I'm also thinking of the graph where you have like the threshold, right? So this you can think of this like how far should these bubbles be apart, so that we don't think about, so that we're not afraid. Like so we think that we're under the threshold of acceptable missrate. Most patients will present like with some features of this, and we hope that maybe I can find something else that will rule this out, so that I only have to only do the troponins or only do something else. But sometimes you don't, right? Sometimes you don't find that extra thing, and then you just have to. Oh well, I guess I have to work this up. So yeah, this is the situation most of the time, and notice we always, even though we will always have what you call patients tell their story no matter how, like they will almost never present as the textbooks. And if they present as the textbooks, then usually I'm kind of, have you read the textbook like before? Are you a med student? Because if they use language that is kind of medical, then it's always kind of concerning for them being not hypochondriac maybe, but anxious, and having read a lot of literature beforehand and think this is it. But most of what they say will not fit the exact textbook. So there's this irreducible amount of uncertainty always. I might send this patient home and say, this is not good enough. It's not good enough for you to do a CT scan, or if it was testicular torsion, where the best test is the only test actually is to do an operation. It's not high enough. It's not high enough risk. I've reduced it as much as I can with the twist score and with the ultrasound. I point of care ultrasound. It's not good enough. Like so this is what we have to accept this irreducible uncertainty. We have to be able to be okay with that, and that's a hard thing sometimes. And usually I share it with the patients, because oftentimes these decisions can only be shared with the patients. But if we share that with the patients, we must be willing to actually give them the test as well. And that's a hard thing, because we really don't want to do the test. And if we really don't want to do it, we shouldn't. Do shared decision making, because we should be willing in shared decision making to actually make them, like the test should be on the table. Okay. Aortic dissection, like when we talk about our illness script, most aortic dissections, or some illness scripts, some diseases might present at the bell curve, right? Most of them have chest pain, some of them have dyspnea, and so on and so forth. But some might present a bit different. Like appendicitis is famous for like having a vast amount. Like if it's classical, it's classical, but you don't need, like, even med students or even like lay persons can diagnose an appendicitis if it's clear, right? But if the appendicitis history is like, oh, it's like 2 weeks instead of just a few days they have symptoms, it's not really hurting. So just to illustrate that, sometimes some diagnoses have a different spectrum and might have like a camel's hump, not a bell curve, but a camel's hump. Like there are two kinds of ways this patient presents, two kinds of age groups, so it might not be this, like, as we think, the time critical, or the illness group that's always presenting. Like sometimes they present, some diagnostic groups like aortic dissection has a vast way of presenting. There is, like, most of them present with chest pain, right? But the curve is different. There's a long list of atypical presentations. So I just want you to think about that. Like it's not like when you are trying to mature your illness scripts, that some might laugh at you when you say, oh, why are you working up this appendicitis? Obviously not appendicitis. No, I know it's not, probably not, but it's over my threshold. It's over the threshold, I think, to work it up, and I haven't found anything else. So I'm not saying so they might say, oh, it's obviously not. No, I mean, 9 out of 10 times it wouldn't be, but that means that the threshold, like the post-test probability I'm at right now, is just 10%, and I want to go down to 2%. And sometimes you can just, okay, I have to follow these patients up instead of just working them up right now. For appendicitis, you can sometimes just follow them up tomorrow with an ultrasound or something like that. Sometimes that's one of the groups that might be a pathway for that, but others you can't. And just don't be disencouraged by colleagues or other specialties who like think like we're stupid for doing this. Usually they don't understand the logic that goes into it, the threshold thinking, and it's important to think about that. Okay, I said I wanted to talk about the acceptable miss rate. Here it is. So how many patients do we want to miss? How many ACSs do we want to miss? How many subarachnoid hemorrhages do we want to miss? When you ask doctors, usually they say no. But if you know about probabilistic thinking, you know this. Usually they say 0. But if you know about probabilistic thinking, you know the answer can never be 0. There will always be a asymptomatic, or asymptotic, like a gradual like decrease of risk. But as the risks go beyond below maybe 2%, then the risks of overdiagnosis and harm to the patient, especially if that kind of decision becomes algorithmized, like that's how we should do it, then it will hurt a lot of patients. So we have to think about where is the acceptable miss rate. And as they said at Swedes, or the Swedish yearly convention here in Stockholm for emergency medicine, or not in Stockholm but in Sweden, they in 2024 there was a lecture that asked what are we willing to make it cost, right? What are we, because we are in tertiary care, right? We are in the hospital. This is like, sometimes we can save people. Most of the times what we do is like just reduce risk, and that's important. But isn't it more important to use this money for primary prevention of like good schools, psychology, psychiatry, like better roads, all of these things is more political, right? But and we shouldn't think about that at the diagnostic moment. But right now, when we're thinking about the concepts, we could take this into account, because the acceptable miss rate, I mean, we could, let's see an aortic dissection. Numbers needed to CT scan for I might need to CT scan 200 and 250, or maybe 200 or 100 to find one aortic dissection. Maybe it's 10. I don't know the number here, or no one knows. But if we also want to, and I might be able to achieve this by if I just go on the typical symptoms, right? If I scan everyone with a typical presentation with sudden onset chest pain, who is above a certain age or has some risk factors, right? But if we want to also, if the hospital might say, oh, we missed 2 or 3 of these in the last year, we want to be better at this. These were missed because it was without chest pain, but they had syncope. Should I work up all of these as well, just with CT scans? And then I might, then the acceptable miss rate, so the acceptable miss rate goes down. We also want to incorporate all the atypical presentations. Well, sure, but then I have to CT scan 1,000 maybe. That's a lot. That's a lot of crowding. That's a lot of, for just to find one more. That's a huge investment, right? I'm just making up these numbers, but it's just like the concept of, if we want to decrease the acceptable miss rate, we are making the population in the emergency department wait longer. We're making them crowd longer, and we're creating problems. And that might be a good thing if it's a disease that is really horrible, and it's but what is, how we will have to ask the question: how many aortic dissections should we miss? Right? How many subarachnoids should we miss? What is the appropriate amount? And there's no specific answer for that, but we have to quibble with it, because we do it every day. That's what we do when we're sending people home. They have some spectrum here of the risk, right? When we say it's quote unquote ruled out, we're somewhere below the threshold, acceptable miss threshold. We could also say, it doesn't matter. Only the very typical, okay? Only the mafangnoids, the ones with mafang, only the patients that have high risk we should scan. Then we'll miss more, but we will have a better hit rate, right? And some would argue that aortic dissection is such, there's no good test outside of the CT scan for it, right? There's an argument of the ADDRS score with D-dimer, and maybe with or without POCUS. I mean, and I'm all for using that, but we need to talk about the acceptable miss rate locally before we do it, because it's not really validated. It will probably reduce the amount of CT scans we do, but we might come into other problems, right? And when we miss, because we will miss, it's a numbers game. What we will do then? Is it okay? And then it has to be backed, right? It has to be backed by the department. So that's just what I wanted to say about the like acceptable missrate. It's something that has only been studied in PE, as I know, and something that we need to think about. And if we want to reduce CT scans, this is a conversation that we need to have on many of the illness scripts. So arachnoid hemorrhages, aortic dissections, PEs. Okay, what is the acceptable missrate? And what is the department willing to back up? Can we use ADDRS scores? Can we use POCUS instead? Seems like no one wants to have that conversation, and the only emergency physicians who work with this each day can have that. And yeah, so I keep bringing it up, and I hope you guys will keep bringing it up because this is so important. This is, as a society, we have to think about this. All right. I haven't, in this part 1, I haven't talked about the Fagan's nomogram. Again, check out my probabilistic lectures if you want to know like more details about the probabilistic way of thinking here, like this lecture. Yeah. So again, what is the cost? Finding critical conditions versus overdiagnosis, crowding, and resource if it's resource heavy. Most of the conditions, ACS, there's such a high probability and it's a good treatment and so on. Aortic dissection, yeah, if it's classical, maybe. If it's atypical, I mean, what's the numbers needed to scan? What is the costs? Or at a society level, like both through crowding, through all the CT scans that we order and so on, like what are the costs? So right now my answer is we have to do shared decision making with the patients. Guidelines should incorporate numbers needed to treat, numbers needed to harm. Time as a test, deliberate cognitive inertia, reframe culture of misses, right? And like we don't have to be persecuted if we miss something. We have to have a local culture where it's accepted that we do miss. If we do, and we have to learn instead of missing. All of these things we have talked about before. So yeah, so this and that's yeah. This is just another way of showing it. Like we in emergency medicine is the needle in the haystack problem, right? We shouldn't burn the hay. Like we shouldn't do CT scans on everyone just to find one. We should do an evaluation, right? So, and the thing is, how is it 1 in 1,000, 1 in 100, 1 in 10? What is the acceptable miss rate of different differential diagnoses? Okay, how to gather data with your patient and communicate with the patient. I've gone through it in these lectures. Please check those out. In short, sitting down with your patients, using validation techniques, using what you call expectation management. What can we do here and what shouldn't be done here, time-wise as well. Flying ahead of the plane so that you can you can give them a plan there and then, and so you can go do that plan once you go back to your desk, and be cognitively deloaded. Sit and you have to you like all the non-verbal and verbal things that are important. Sitting down, eye contact, asking broad questions to begin with, like why did you come to the emergency department today, and trying to tease out what is the reason why they came today, like not just the presentation symptom, but also like why did they came today and not yesterday? Like is it end of the rope? Like have they been desperate, or is it just because the pain went up, or it's because the symptom hasn't gone away? Like that, this informs your pretest probability as well, right? Let them tell their story. Don't interrupt them once you've asked the broad question in the beginning, and you can nudge them, but don't interrupt them, and ask them to clarify if it's something you don't understand. But let them tell their story, and then you work them up, and then they have to get their story back afterwards, right? As Sanders talks about in her book and in her lectures. How the patient tells the story, I think it's called the book. You have to give the story back to the patient, like in their frame of reference. How do they understand? Like because you have so many patients that come back to you and say like, oh, we didn't get any workup at the other place, and they got a lot of workup, but it just didn't understand the workup. So take 5 minutes in the end of the seeing the patient, just to write down a plan. Step one, like in three points maybe. I don't do it with everyone, but most I actually do this. Write out patient information for them if they need it, and what their next steps are, right? And what the treatment are if those steps occur, and when to come back. And like sometimes I write out the blood samples and the CT scan answers, so they just can see, like tangible, see, here's the blood samples, here's where you were, here's how you are now. This is normal. This and make sure that you can't answer a emotional question with a factual answer. So I'm afraid to go home. Like, oh, but your troponin is normal. That's a logical answer to that emotional question. You should instead say, get it, like as you call Laura Rocks, I think, the ones who did a SMAC lecture on this. You should get it, get that they have. And get that they have an emotional response instead of a logical response. Identify what it is, like. It's like, oh, it's anxiety. This, okay, let's try to explore it, and then try to like validate it. Oh, you're afraid to go home because you have chest pain. Well, I can understand. I can relate to that. It's really like, I know. I'm not afraid that you have chest pain, but I cannot take your fear away from you. We've done the workup here. You can see and what I would advise you is this and this and this. All right. So you can, like, you can't answer like, oh, but your troponin is normal. Like, you can't just dismiss it. You have to validate it and then try to like identify the feeling if they talk about it like that. Okay. All right. So let's go into these lectures if you want to know more. And also this one. Okay. How do we know, and guidelines? So this is the last part, this part one. So these are some great lectures on what I'm about to talk about, which is epistemology, or how do we know? In general, how do we know things? Like, how do you, if the patient asks you, how do you know that this is what you have to do? Well, I could say, well, mechanistically or bioplausibility, I could argue from a bioplausibility standpoint, saying that, well, the body works like this, and this is how it works. The problem here is that 200 years ago, our paradigm was maybe like the Galilean way of thinking, right? So the bodily humors, we had to blood let people with sepsis because we thought that made sense. And we might think that we, in many ways, are beyond that now, but we aren't, or we still have, like, we still think too highly sometimes of our understanding of the body and our physiology. So it's again this yin and yang, because yes, it is really important to use the physiology and know the physiology to use it, but we should also be humble to know that, well, the physiology in critically ill patients or the physiology in even stable patients has not been understood all the way, and it's complex, and there's complex interactions, and it's not just like easy to treat or easy to so there's this and that's why you often get paradigm shifts in different ways, like so yeah, the physiology, there's good reason to use the physiological or mechanistic argument, like the body works like this, we should do this, but there's also caveats. An example is put in a like all patients with bowel obstruction should get a GI tube. Well, physiologically might make sense. Like you can pump out the stomach so that it's not full, and you can make the patients not have any content in their stomachs before operation. That makes some sense, right? The problem is when you do studies on them, it doesn't. There's been done really few studies, and the studies are not encouraging for the practice of this, like for a gastric tube for all. Nevertheless, that is often what our surgeons will say because of tradition. We'll talk about that later. But that's like a physiological argument where we think we know how the body works, but we really don't. Fasting rules is another one. There's like thrombolysis for stroke is another one. Like we think it's 1-to-1. It's more nuanced than that. So there's lots of these. We think physiologically, oh, we should do this, but it's probably not. Then you have the other way of arguing how we know is experience or empirism. And wow. Okay. Yeah. Here you have, and you can part this into two things: either systematic, which is in modern day time called evidence-based medicine. This is a brand, right? But it's usually what is pathognomonic with, or synonymous with, systematic kind of thinking on a population basis. So this would be doing studies on patients, right? And then you have the unsystematic way, and this would be your own local experience. And all of these boxes are important. You use all of these every time you do decisions, right? It should be informed by the best evidence, but also in the individual patient, because evidence is not too good with the individual patients. We need to know about the physiology. We need to know about our own experience with these patients and so on. And this is incorporated in the evidence-based medicine, right? That is part of it, like the studies, but also the clinical assessment and our own expertise and so on, and then the patient's values. So this is how we know. This is the epistemology of how do we know something? How do we know that this patient should get a CT scan? How do we know that this patient could have a gallstone and so on? That's from our workup and so on. That's how we know. And you have outside of this, you have guidelines and traditions. And guidelines is somehow trying to reduce the variability, right, of doctors, so that most do the same. There's other purposes of guidelines making it like, but that's one of the reasons, right? And then you have tradition that is not really logical, but we always done like this. We'll just keep doing it like that, and it could be reasonable. Because it might be hiding experience through time. It could be, and it might be hiding some physiological things that has been unexplained. But we should always be skeptical and try to do studies on the traditional things to see which bucket it actually falls into. Guidelines is a problem of their own, or a solution of their own, depending on which side of the argument you're on. First 10 Justin Morgenstern and Jerome Hoffman, who often are thinking alike, are definitely on on the skeptical side of why should we need guidelines, but they also are really well read up. One of the things of guidelines is that you kind of try to, like, there's so much to read in even one field of emergency medicine or even one field of medicine. So you couldn't possibly read up on all the studies that you need to read up on in a field. They've done studies on that you can't. There's not enough times. There's not enough hours in the day to do that, even if you tried. So we need some kind of condensing mechanism, right? And AI might help with this, but right now it's guidelines. And the problem is with guidelines is the way they're done is they're usually done a little bit too simple for being able to be used for the individual. There's several problems with guidelines. They're biased because they're usually different talk, right? But the pharmaceutical and universities, they try to, like, they produce studies and they're often sponsored, and these sponsors also often jump into guidelines, and they fund the big organizations, the AHA organizations of the world, right? The American Heart associations and so on. There's ties to money, and the money from pharmaceutical industries gets into the guidelines through conflicts of interest. Directly or indirectly. Just Jerome Hoffman and Jeannie Lenzer has made great studies, and John Ioannidis have also done studies on this, if you want to check them out. As a professional, like the professional biases is like, if usually the ones who make the guidelines are usually not, or not usually, they might not, like they might only represent a one part of the argument, right? They are not the broader view of this problem. So they might invite in one of 8 that might disagree with them in certain things, but they're not like exploring the disagreement in a representative way. They often look through the lens of a specific guideline society. So cardiology might recommend this thing, but nephrology might recommend a totally different thing. So which one is the right one? Which guideline is above the other, right? Is there consensus there? No. Which one should we follow of these guidelines? Oftentimes, if you have to follow all the guidelines, you will not be able to treat any patients, right? So it's like it's and then there's also like diagnostic creep. Many guidelines, because of the biases and so on, like from a cardiological standpoint, if patient only concern was cardiology, then yes, hypertension should be treated on the population level down to maybe 130 or 35 or whatever. But in the multi-sick patients, geriatric patients, maybe 160 would be acceptable, or 180, especially if you're septic right now. Like all of these, like they are not contextual, the guidelines. They're not situational. They're not usable in the real world. Oftentimes you have to fit the patient into the guidelines somehow, and that's what we try to do. But it's like oftentimes not possible, and the patient right in front of you is not the one who can be treated like this. Maybe we don't know, and what we actually wanted to do was to be more nuanced. Decisions would be if the guidelines had numbers needed to treat, numbers needed to harm, and likelihood ratios. So if, as I'll come to, if a ovarian torsion is high likelihood if it's above 5 centimeters, what if it's 4.5? How does the scale look here? Does the risk decrease momentarily? You get on the other side of 5 centimeters, or is it like gradual? We don't know, and we have to know this from decision making. But usually the guidelines make statements that are too big from the evidence that is actually there, and because the guidelines are viewed as a golden standard, then everyone is doing it because it's the safest bet, right? But actually, the studies say something else. The studies are more nuanced, so that's also a problem. They also reduce what you call appropriate variability. You want to go to the same doctor and get somewhat the same treatment. But the thing is, people are complex machines, right? And doctors are complex machines. So oftentimes, if it's not really, really important, then oftentimes there is some variation. And sometimes there's inappropriate variation where you should really treat all STEMIs with this and this and this. But oftentimes it's appropriate variation. Like in this circumstance, it's probably not as good to do this. Like you shouldn't treat everyone like as a nail just because you have a hammer. You should treat patients as like individuals and see like what they need. And it also gives the illusion of certainty about the evidence. Like the evidence is usually kind of weak. The guidelines are becoming better at saying like what grade of evidence, but people usually don't like. There's only grade C evidence on this, but it's the only thing we got. So we haven't read the studies, so we will have to do this instead. And then oftentimes we don't have to do it, but it's in the guidelines now, so it's just we have to. Yeah, and then there's the erosion of expertise. That's mainly clinical decision rules. And algorithms, that is a problem here, because if we do make guidelines with algorithms or clinical decision rules, then being an expert, getting to know which patient we should actually work up, erodes from us. And oftentimes guidelines exist in a vacuum. I already talked about it, but they usually exist kind of in a vacuum. They only they're only used for people who are one thing that comes to mind is the syncope guideline from the ESC. Like they say like you have to have centers where you can work those people up. And yes, in the best of worlds and with an unlimited amount of money where you don't have to think about other things in society like schools and roads and so, then maybe we should do clinics for syncope workup. And that might be a good thing even though, but it's just, even though the evidence says this in an optimal situation, then giving a broad recommendation of this doesn't really take into account how it's in Africa, how is it in any other countries, right? And maybe that's how it is, but but maybe that's how guidelines should be, but it should just be set clearly then because we are, like, when we're not creating these clinics, we're seen as bad doctors, right? And that's a problem as well, right? So they're, yeah, and then I've already said that they're not coordinate. The guidelines are not coordinating with each other. So one guideline might say almost an opposite thing, and when you see, like, there's usually studies of that does a cross section of all guidelines and see where they agree and where they don't agree. And as doctors, what do we follow then? So yeah, this is from a recent study that came out from Pavluri. And they say the challenge lies less in the guidelines themselves and more in the numeric cutoffs that define diagnosis and guide treatment recommendations. Clinical practice guidelines reflect how different societies interpret and weigh evidence, but the underlying problem is that the evidence base itself often admits a spectrum of reasonable thresholds. For example, in ovarian torsion, as was the example as I just used, the risk increases with ovarian size and is most often associated with masses over 5 centimeters. With no definitive size cutoff mandates surgical intervention, torsion is considered less likely in the setting of an ovarian mass under 5. This variation creates a complex scenario for emergency physicians. Consider a patient presenting to the emergency department with a left-sided 4 centimeter ovarian cyst, mild left abdominal pain on ultrasound showing Doppler flow to left ovary, findings that may or may not exclude torsion. If the patient is discharged with strict recommendations and later diagnosed with ovarian torsion the next day, would this be considered a diagnostic error? The example is a pragmatic illustration of how real-world medical decision exists along a continuum of reasonableness rather than a single gold standard. The emergency physician acted within the reasonable identity thresholds and accepted the standards of practice, yet patients' underlying pathology ultimately declared itself later. So they made this, and I'm not sure. I think what they said in the text is the main thing, right? It's a spectrum, and there's not just one gold standard, but they try to make this where it's like evidence alignment. Does the guideline or evidence say? And what is the reasonable quality? Like, what is the local? What do I think? What is contextually shared decision making? How is my evaluation of the patient? And then you have boxes where it's like it's both bad evaluation and you're not following the evidence. That's bad, and or you the guidelines align with what you find. That's great, but then you have these zones where you think something and the guidelines says something else. Recent deviation of contextual justification, sound reasoning despite limited or conflicting evidence. Like yes, the guidelines don't say anything great, or in this situation, I don't believe they apply. I just have to write in my chart. I just have to write how. And then outcome aligned with evidence despite incomplete reasoning. Well, so I do this because the guideline says so. I'm not quite agreeing with it, but I will do the CT scan because the guideline says so. And the CT scan was negative, but it's defensible because the guideline says so. Not that I thought so. Yeah. So take home for part 1. These aren't essential. Time critical plus likely for the symptoms the patient is presenting with should always be ruled out. Could be done directly or indirectly. We need to know the illness scripts. Emergency medicine is a balancing act. And the models shown can help you solidify probabilistic thinking by using them in case-based learning. Where do you go from here? Well, see the patient and reflect, so as we said, and shadow box with your patient. With your colleagues. Do prospective case review. Shadow boxing. And I like to advise that every time you see something in the emergency department, or just once per week or twice per week, go and look up like how to treat this, to like explore your illness scripts, and maybe have a small archive in your phone or in a database with these illness scripts where you have articles and guidelines on this, so you can look it up, so you grow your illness script like figuratively and literally. Every time you see a patient, you can practice this. I've talked about forcing strategies before, but every time you see a patient, use this chart, this 2x2 table with time critical and non-critical, and see like, okay, give me 3 dangerous diagnoses, and how many percent are left? Like these make up 10%. Are they all over the threshold? Yes, they are. So I need to work them up. But how about but 90% is non-dangerous. So you kind of to practice this. I've talked about it in the other lectures, so I will refer you to that. Then study. Yes, we need to become experts and not just amateurs. To think strategy and not to think logistics and not just strategy. You need to know the illness scripts. You need to know those. Sorry, a little edit here. After the take home of part 1, I came up with, or remember that there was another thing that I wanted to talk about before ending this part, and that is charting or documentation. Because one thing is what we say to the patients, that's important, and another thing is what we do in the clinic. But charting must reflect our thinking as well. And there's a lot of defensive medicine, especially when you read the North American literature and hear North American podcasters talk about this. But there are some truth to some of the things about charting. So I'll try to how I chart. I'll just try to explain how I chart, and show you some references where some people, important people or good people in this field talk about charting. So like Rob Orman talks about it, about documentation. He's big on templates, having templates that you made already. That might be a little bit too defensive for me, but it's in line with this experts talk strategy or experts talk logistics kind of thinking. Then you have Justin Morgenstern, who's made it great. How should we reflect, like in the conclusion of your chart, how should we reflect certainty or uncertainty? So when we admit patients, usually it's not like we'll come to admission and disposition in part 4, but when we sit with patients and we need to admit them and we need to chart what we think it is, should we put a percentage on those conclusions? Like 70% we think 70% that this is what it is, but it might also be this. I usually in words talk about this, like this and this and this, like says that it might be diagnosis A, but keep in mind it could be this. So if the patient develops this and this and this, call someone to evaluate this and so on, right? I'll make that kind of conclusion. Here's some of the templates that Rob Orman makes, and here Ruben Strayer talks about these charting templates as well. So if you want to, he's also one of those people who's talked about this, and Scott Weingart as well. So check out those to like, that's a North American kind of take on this. I'll just give you my take. I've worked in different systems in Denmark and in Sweden and in Greenland, and it's kind of like different places, different kind of charting, right? And different contexts demands different kind of charting. So in Denmark, primary care doesn't chart that much. They chart for themselves, and when you have to go to the emergency department, then they will write you. They will write that kind of like statement of what you need to do. They will write a letter, so that's summarizing their problems, right? So they do what they call a SOAP note, SOAP, as in subjective, objective, analysis, and plan. We in the emergency department in Sweden, we would do it like this, and it was not too different in, like, this part is not too different between Denmark and Sweden. So presentation, like what does the patient present with, Mabel's in some way of like what the or the order is it's totally random from place to place, but I usually just go with Mabel's. Medications doesn't always have to be in the chart, but they do have to be in the system. So most systems now have like this, like some kind of digital add-on where you put in the medications, but oftentimes medications, depending on how secure that system is and whether you can go back in time and see what medications the patient had when they were admitted, then they do need some kind of charting of the medication. But in Denmark we didn't do it where I worked, and because the system was more secure. In Sweden we're getting a broader system where you could potentially get away from doing all the medical charting, but right now it's quite new and it's not that good. So all right then, but it will develop like we did in Denmark, I'm sure. But you do the other kind of Mabels, and you do and it's important, like with allergies, that you actually write what was the reaction and when was the reaction, right? So and you could check out EMK's allergy thing, because oftentimes we put in allergies that are not allergies, and we should critique the allergy. Like most people are not allergic anymore, so we kind of should talk with them about that. And previously, I've usually put in previously quite thoroughly, because it's not getting updated through the through the entire thing, through the entire admission. And I mean, I would not just say heart failure, I would say left-sided heart failure. I would look at the echo charts and to see what kind of heart failure it is. But I would, when it comes to like, so I'll usually do a diagnosis and then sometimes a year, like 2000 or something, and then I would like put in a few details that are relevant to the case, but not too much, like maybe a line of things, right? Some places do like what are the current diagnoses and what are the previous diagnoses. Like you can do it in different ways, but I there's just like, and when you're looking at a chart, like an orthopedic chart would be focused on just the orthopedics oftentimes, or what is tangible, interesting for orthopedics, like blood thinners and so on. But in an emergency chart, I mean, you should not do it so thoroughly that you take too much time with it. But usually, I don't think it takes too much time to just run through the chart, their previous charts, to like get the diagnoses, and especially for some diagnoses like Alzheimer's or dementia, it's really important to know what's their social situation. When was this diagnosed? But there's lots of charts ghosts. Like one feather becomes a entire chicken or a dragon or whatever. And then when you in the emergency department says, oh, it was Alzheimer's. No, it wasn't Alzheimer's. They just had some delirium a few years ago, and then they were never worked up, and then so I would counter that in my charting then and say, maybe cognitive deficits but undiagnosed. Look at the charts from this and this date, so that you kind of like, you know where to look, and especially when you have to make a decision on treatment, when you have to stop treatment on certain patients, that Alzheimer's diagnosis becomes really important oftentimes, right? So in a perfect world, we would be able to go back to the source of the diagnosis each time, and I don't do that with all diagnoses that I have in the previous kind of thing, but I do with some that are relevant for this current presentation. If I'm in surgery, I want to know where were they operated and how were they operated, what kind of procedure and so on. If I know it, I'm like, and if I don't know it, then I would not write it specifically, because it's worse to write something specifically in surgery than not. So now, but rather I just say they were operated on, and then the surgeon has to find out what kind of operation it was. Okay. Then you have the leisure, and the leisure is really important, like mobilization, where do they live, what kind of house is it, and so on, especially with elderlies, right? And so on. And drug history, all right? And then you do the OPQRST. I usually make sure that in the description of the history, what the acute history is for the patient's presentation, I usually make sure that the OPQRST is here. But I might also fit in why they came today, what they have had previously, like have they had similar previously, and so on. It depends, right? Then you do your status, like, or your examination, and maybe you'll put in vitals here. Vitals is part of every system, just like with medication. Usually you'll just put it in somewhere else, so you don't have to double register vitals. And usually there's a standard way of doing the status, like different in different countries. And then usually after that you'll have the paraclinical, blood samples, imaging, maybe POCUS, and so on, urine dipsticks, and so on, pathology. Yeah. And then you go into the conclusion, and this is where it gets interesting, right? So in the conclusion, in Denmark, we did it in a quite different way than we do in Sweden. I might be biased, but I think, but I have some Swedish colleagues who agree with me on this, that the way that they're taught in Sweden doesn't seem too coherent with what you need in the clinic. Oftentimes the conclusion is just jumped over, and that's the most important part of the entire thing. So in Denmark, I was taught that you should do like Google Earth. You start off with just a big one. Like all of this above, this is just analysis. This is just like writing off things. But here is where you have to synthesize things. This is where you really have to put it together. And in Denmark, usually you'll do like a conclusion, like so old patient presents with this, and then you'll do a summary of like a very, very short summary in 1 or 2 lines of this. We don't do that in Sweden so much. In Sweden, I'll go in and do. Well, the patient has one problem, maybe there's hit their head, and also they have a wound that I suture. Then if the 2 problems are really similar and it's really a simple patient, then I won't do it like this. I'll just write it out as one problem. But if elderly patients who have hit their hip, also have sepsis, also have cognitive failure, I'll in the conclusion write up each problem, so that each problem has a plan, so that there is not just one big plan that is where you don't know what is treating what. Okay, so, under each problem, I will just do a quick summary why I think the patient has this problem, and what the most likely and time critical conditions are, and how I don't think these are those. Patient presents with chest pain. Sometimes I mix these, or sometimes I change the position of these. This is most likely not PE, perimyocarditis, or dissection because X, Y, and Z. Usually just in 1 line or 2 lines. I don't. In America they would do a lot, right? But here I'll just do a short. Why it's not that. Then I'll after that or before that I'll say, I think this is this. And if it's kind of, I don't know, 100%, I was like, this is probably this, but it could also be this, so the plan is accordingly. And I've consulted with this and this guy. And then the plan, like step 1, step 2, step 3, or just in bullet points, the plan. So it's readable. So that, because that's the purpose, the next doctor it has to be readable for the next doctor, right? And then you have to say, so that's kind of how I usually will write it up. You can be more defensive. Like the patient has been, like when I was in Denmark, it was a huge wave of defensive medicine where you have to like say, oh, I have done this and I've done this and I've done this and I've done this, and then that just makes the chart bloat and it becomes incoherent. So it's a problem, right? Defensive medicine makes the charts usually worse. Then there's a thing about people reading their own chart, right? And so you have to, I wouldn't say careful, but if you have a tool at work that you use only internally, then you don't have to be too careful of what you write, right? We should be respectful all the time, even though it's not something the patient writes, but you should be respectful and all. But once it becomes something that the patients own, because that's how it is in Sweden, I think it's like the patient own their own chart, so they can they can counter what you they can ask to something to go out of the journal or the chart if it's irrelevant and so on. So I've had that happen a few times as well, where the patient writes and they want this out. So I mean, so we are, and then there's in one hand it's good because then we can write, then the patient knows what's happening to them and they have more power, but over us, which is good. The power balance is less skewed, but on the other hand, it can become a problem if you're working up someone for a psychosis or you want to do a child's there's a problem with their child and you think it might be battered child syndrome or something like this. All of these things are kind of like something that they should probably not read, not yet, or they have a cancer diagnosis that you might work up, but you wouldn't, for some reason, you wouldn't want to say yet to them, or different reason, right? This becomes a problem, so you have to bear that in mind as well when you're writing stuff out. And you might, in some systems, be able to cover these things for a while, but not forever. Okay, just a last quick thing. There has to be coherence between what you examine and what your conclusion says, right? So when you're reading it, there has to be a coherence. So you cannot say that the patient has, or if it's a child, for instance, you cannot say that they're irritable, because at least not in Denmark, because if a patient or if a child is irritable, especially if they have petechia, then that means that they have to be lumbar punctured. Like you think that the patient needs meningitis workup if you say that they're irritable. So you need to know that you need to have coherence between what you're finding and what you're actually planning, right? You cannot say that the patient has peritonitis and then send them home. All right, so there needs to be coherence, right? Otherwise, it's non-defensible. Then I would say this is our evaluation. This is a doctor's evaluation, right? So we can make mistakes. That's okay if it's a reasonable evaluation if we made, right? And yeah, and the patient has been informed of X, Y, and Z, and so on, right? So, and some charts has to be more delicate than others, right? So if it's someone who has been hit by someone, and there might be charges, and it might be written, or it might be your chart might be read in a court, then you have to write it more specifically, right? But if you had to write all of the charts so specifically, it would be impossible to get through anything. So some patients need specific charts if there's it's a high risk of the court being involved, or jurisdiction, or psychiatric and so on. It might need more specifics. Okay, I think that's what I wanted to say about this. Make sure to always check the medication lists when you admit patients, right? And make sure that, like, if you have kidney failure, again, one of these like mismatches, like if they have kidney failure, then you need to remove the kidney failure, like the nephrotoxic medications, or the medication that would, or you have to comment on it, right? So there has to be a coherence between what you say and what you do, right? That's important. Okay. All right.